My name's Rob Pinate. I'm a nurse consultant at King's College Hospital. Thank you for coming. Compact and Bijou, I think this is. It's like my last group. So I was asked a few weeks ago to give the nursing perspective on innovation. Like, okay, what I'm actually going to do is share some of the work that we've been doing at King's, obviously from a nursing perspective, but I hasten to add that actually it's a multidisciplinary perspective. And just to give you an idea of what we're doing there, and I hope it sparks some interest in terms of what might be possible in your departments or in your patch. So I'm going to give you a bit of background, some context as to what it is that we were trying to do and are trying to do. In a nutshell, we are introducing rapid assessment and treatment, which actually has been around for ages. But believe it or not, at King's, we still don't have it. But we're also introducing it as part of a team approach and introducing something that we've called advanced assessment practitioners. Now, that is different from an advanced nurse practitioner, and I'll explain why. And that's kind of the majority of what we're going to talk about. But we've also piloted it. So for those of you who want data, you've got data. All right? So I'm going to share with you some data that we've got from the pilot work that we've done to date. And hopefully we'll have a bit of time at the end, although I do have a habit of rambling on, so just stop me if you want to ask me some questions as we go. So, background. I've worked in 7 emergency departments in London throughout my career, and majors is always the same, pretty much. Okay? It just is. And for us, it isn't working. We've had a fantastic amount of investment into resus in terms of trauma, stroke, and acute myocardial infarction and other pathways. So at King's, we're very fortunate. We've got this lovely, shiny resus department with 10 beds. Very well resourced. If you arrive in our resource department, you are going to get fantastic care and you're going to get senior clinical input very early. If you arrive with a minor injury or minor illness, you are going to be met by a senior nurse who is going to stream you to the right person at the right time. But if you arrive in majors by ambulance or on foot, if you get triaged to majors, you're going to get put in a cubicle and you're going to wait. And you're going to wait and you're going to wait. Now, nurses will put lines in, take bloods, do ECGs, ask doctors if we can start analgesia, fluids, and even a chest x-ray. But fundamentally, you are going to wait possibly 2 to 3 hours before someone goes in and sees you. And then they are going to do stuff with you and actually then probably seek senior support in terms of making a decision about your care. Now, that's a very King-specific problem. Maybe it's different in your departments, but we have not significantly changed it for at least 10 years, and I'm thinking of when we introduced the 4-hour target, probably longer. When I started my career in emergency care in '95, this is how majors worked. If I go into King's today, this is how majors works. So that's the area that I believe we need to change if we're going to make a difference. It's largely passive. I think majors is always going to account for the largest majority of your breaches because of the issues about flow into the hospital. But then nevertheless, we see about 400 patients a day, 100 will go through majors, half of them will breach. Or sorry, they will account for half of breaches. Not half of them will breach. Okay, so, but I think majors will always account proportionally for a greater number of breaches, but still it's something that we need to look at. So that's the first driver, if you like, as far as I'm concerned. The second driver is this. So the Emergency Medicine Task Force set up in September 2011. This was their interim report last year in September 2012. And I won't need to tell you guys that there is an issue in terms of our junior doctors going through training, converting to becoming ST4s and choosing emergency medicine as a career. For lots of reasons, they are choosing to go into other spheres of medicine, such as anesthetics and acute medicine. My understanding is that the figures for this year are even worse, 39%. So there is an issue for us about thinking about the clinical workforce that can work within majors and how we plug those gaps. Yes, we can use locum, of course we can. But I don't know about your experience, but they are variable. They're very expensive. So actually, should we be looking about how we can grow our own clinical workforce that can work in majors, that we can develop and we can rely on? Which brings me to the next point. Clearly, I'm a nurse. That's why I'm here to talk about this component. But I've worked extremely closely with my consultant colleagues, and I want to stress that this is about me working with them to try and come up with a solution for us at King's. So advanced nurse practitioners are widely recognized, but it's not that easy. You can't just pick them off trees, and I'll talk a little bit about that in a second. yes, they're widely recognised as part of the future of emergency care. I've already mentioned the Emergency Medicine Task Force. One of their groups was looking at the development of advanced nurse practitioners within EDs. But it's also mentioned within the King's Fund report, which is appended to the NHS England Improving A&E Performance paper that came out in May this year. So it's being talked about, and I know that there is national work going on at the moment about trying to define what it looks like, because there are areas and centres that are already doing this, way ahead of us at King's. Particularly, springs to mind would be Birmingham Heartlands, would be some centres in Manchester and Southampton, to name just a few, who've got really well set up systems. But it's patchy. It's not necessarily consistent in terms of everywhere within the country. So here are the three drivers as far as we see it. So that's the background. Solution, well, easy. Bring in rapid assessment and treatment, and get lots of advanced nurse practitioners and throw them into majors along with your medical workforce. It's not that easy. It really doesn't. It's not that easy. Bit of background about me. I was fortunate enough to get a secondment to King's between October 2011 and March 2012. I did 2 days a week. So I was still based at the Whittington, which is where I was, and 2 days a week at King's. And I was asked to look at introducing advanced nurse practitioners. And it's not easy. So if we break that down, I worked very closely with Dr. Malcolm Tunnicliffe, who's our clinical lead in the emergency department, and we knew we wanted to do this as part of the overall way in we were going to change majors. So we knew we wanted to do this, and here's a very basic description of what nationally is accepted as rapid assessment and treatment. Senior clinician at the beginning of the patient journey, largely for majors patients, usually taking ambulances and making decisions about care, so front-ending that senior input. For us, we actually felt that there might be some issues about that for where we work. We have about 100 patients a day come through majors. We have 100 ambulances a day that come to King's. Now, only 50 of those ambulances will actually offload in majors. The rest will be resus, some in minors, some in peds. But we felt putting a sole clinician in a room, having ambulances coming at them, where we can have queues of literally 6 or 7 or 8 ambulances at any one time, that we won't necessarily see the benefits of that sole clinician input, however senior they are, and actually they're going to get burnt out. If we just stick them in a room and throw all these patients at them, they're actually going to get burnt out. So we didn't really feel that that particular idea of a sole clinician seeing patients coming in by ambulance was necessarily the best way for us to do it. So we came up with this concept of RAP+. And basically, RAP+ suggests that you have a team approach. So don't just put someone on their own with a tech or with a nurse. Actually, create a team. Because that way you can deal with the volume, and obviously they're supporting each other. So this is the RAP+ model that we've developed at King's, which is, it has the idea that, yes, you have a consultant doing rapid assessment and treatment, absolutely. But you don't lose your senior clinical input in majors. You have both. Because then you have senior clinical input at the beginning and during and at the end of the patient journey for the majors patients, not one or the other. We're going to introduce advanced assessment practitioners, and I'll come to that in a second, and they will also be able to see those patients coming. So it's not all on the shoulders of the consultant, but the consultant is there for advice. And we're going to use our emergency department technicians. They already exist. But we're going to move them into the rapid assessment model, because actually then they can do their bits early on in the patient journey. So that's RAP+, so just keep that in mind. And then let me talk about this AAP thing. So you will have heard of advanced nurse practitioners, but actually they are well recognized, but very difficult to find in emergency care. So let's just go through some of the definitions. This is the NMC definition from 2006, well, part of the NMC definition. And despite all the work that's gone into defining what an ANP is, it's still not a recognized part of our professional register, and doesn't look like it will be. The RCN and the Department of Health also released papers in 2010, so you get the sense and idea of what an advanced nurse practitioner is. if I can just pull your attention to the fact that the DH very clearly said that those individuals should be master's level trained, which is slightly different from the RCN, which said degree level. I think most people now have very clearly signed up to the idea that these individuals have to be educated to master's level if they're going to take on this. Now, one of the things about all of these definitions is they're defining advanced nursing practice within the broadest sense. This isn't ED definition. This is a very, very broad definition. So, what are the challenges? And this is what I had to look at, because King said, right, great, Rob, you're here now. Let's have ANPs. They're not widely established. I've mentioned some centres where they are. They are very high level. It is not simply a case of taking your emergency nurse practitioner in minors who's been working, and who's a fantastic nurse practitioner, working in minors for 10 years, and going, do you know what, tomorrow I'm going to put you in majors. Why don't you go and see some chest pains? You simply cannot do that. So it's not just taking an EMP and putting them in majors, it's much more than that. So we need to think about growing our own, because if you want to advertise for, let's say, 6 advanced nurse practitioners because you want to start a 7-day-a-week service in your emergency department, good luck, because they ain't out there. So one of the things I had to do at King's was then look at the nurses that we had, the senior nurses, and the question I had in my head was, how many of you already tick all the boxes to be an ANP right now? None of them, not one. A lot of them are incredibly experienced nurse practitioners, but they didn't actually tick all of the boxes, both in terms of competence and educational level of training. We've talked about the master's level. So we had to think, actually, how are we going to develop individuals to be ANPs? In other words, you need to grow your own. So we came up with the idea of the advanced assessment practitioner. Why does that differ? I really apologize about this very wordy definition. In fact, it's not really a definition, it's more of a description. It's taken from the job description which I've created to define what an advanced assessment practitioner is. So I'll let you just read that for a minute. So you get the sense of what we're trying to describe. Okay? And you might think, well, that doesn't sound very different to an advanced nurse practitioner, but I'll come to that in a minute. We set an experience level. This is absolutely bare minimum. They must have already done an advanced assessment or physical assessment type education at master's level so they can actually assess a patient clinically. Must have at least 5 years, but actually the people that we're currently pulling from have more like 10 years of emergency nursing experience. And it is an advantage if they've got emergency nursing experience, because then they're used to seeing undifferentiated patients, taking a history, doing a physical exam, ordering investigations, making decisions about patients, and either referring them on or discharging. So actually that is an advantage, but it's not something that we say excludes others from doing this role. So the benefits, as far as we see it, is that it establishes nurses working as practitioners in majors, because you're doing AAP quickly whilst they're developing towards full ANP status. And that's the whole principle behind bringing this in. But they cannot discharge a patient independently from majors. So that's the caveat. An ANP would be able to, but that takes years of experience and training, at least 2 years on the master's program. These guys can't do it. So if they've got a patient that they truly believe they can discharge home, they have to discuss it with a registrar or consultant. They may not be able to prescribe, but actually most of our practitioners can already. It's a new role. So with any new role, obviously there are risks, and we try and mitigate those risks as much as we can. We've not had any clinical incidents thus far, touch wood, through the pilots. I think this is really important. They require educational and clinical support. I couldn't have done this had I not done it with Malcolm, our clinical lead, who's very supportive of it, and the other consultants. We have currently 16 consultants. So, you know, it's all about making sure that there is buy-in from the entire senior clinical group. I couldn't have done it without them, absolutely not. So we had this idea. So remember, we've got this RAT Plus idea, team approach, and we've got these advanced assessment practitioners as part of the RAT team. That's what they do. And we did 2 pilots in 2012 when I was there on secondment in January, and then another one in February, March. Okay, so here comes the data. So let me just explain how we derived this data. First of all, when we did a RAT pilot, we'd do it, let's say, for 4 hours during Monday. We always knew that the RAT team wouldn't see absolutely all patients that came through majors that that particular 4 hours. There was going to be some patients that were not ratted versus some that were ratted. That gave us our 2 groups. So this is the traditional route through majors that I've talked about, whereas this is the rat group. But what's good about, or I think it's good, what's good about this data is that all the patients in the data pool came through the department at the same time on the same days. So if there's problems with beds, it affects both groups. If there's problems with labs, it affected both groups. If there's problems with X-ray, it affected both groups. If there was staff sickness, it affected both groups. So they are comparable. So, and then what we did is we looked at, and this is very time-based, and we need to do a lot more work in terms of the qualitative elements of care, not just time. But we looked at, obviously, time to being seen from arrival, how long it took for for the patients to be referred on, what was the time differential between being seen and having a decision made about you, then obviously the total time you spent in ED. Now, there's a huge caveat about this column. The way the RAT team we designed it works is if you've got a patient where it's difficult to make a decision there and then about where the patient's going to go, they can refer it back to ED for further workup. So I'll give you an example. A patient presents with chest pain, and your differential is actually dissecting thoracic aneurysm or an ACS. So we would put in place the investigations necessary to rule out the dissecting thoracic aneurysm, but we're not going to hang around and wait for all the results to come back. So we're then going to hand that patient over with all of these things already in place and happening back to ED. They'll wait for the results, and then they'll sort the patient out. These guys can't refer back to themselves, okay? So just bear that in mind, and we'll come back to it. So I'm not going to ignore it. I will come back to it.
I'm confused how you allocated patients to those 2 groups.
We didn't. Next one in the queue. As soon as a rat person was free, they just saw the next person in the queue. And if a non-rat person was free, they would just see the next person.
And there wasn't a selection by which somebody serious comes and you say, well, actually, we're going to rat this one.
No, I was very, very careful not to try and introduce bias. So my job really was actually to oversee the AAPs, because obviously it was a new role for them, and also to help my consultant colleagues, because they would want to go off and do this. And I'm like, nope, that's not the model. You've got to test the model, and then we'll see if it needs changing. So consistently achieving the time to treatment QI for 60 minutes versus the non-rat group. The decision-making seems to be quicker with that huge caveat, and the time it takes for them to make that decision is half. Total time in ED? Marginal. So 59 hours of cover over 9 days. They saw 42 patients. So that's not a very good hourly rate. The vast majority of these patients were seen by AAPs because we couldn't release the consultant time to do the pilot. So we had great difficulty, but we always still had a consultant in majors, so the AAPs were supported. So that's why most of these patients were seen by AAPs. So we started to get a sense that actually this might be a good thing. So at the same time, Malcolm and I put in a bid to what was then Medical Education England, now Health Education England, Better Training, Better Care project, and it was successful. And we wanted to obviously to take this project further, look in more depth about the effectiveness of it, and we were successful. So in August of 2012, we set up the RAT Plus project board, which was Dr. Ed Glucksman, who's our clinical lead for the division, Dr. Malcolm Tunnicliffe, who's the clinical lead for ED, and Dr. Robbie Hock, who's one of our emergency physicians. So that was us, that was the group, and really what we wanted to do was to do further pilots, and BTBC had given us some funding, primarily to release the nurses off our rota so that we could use them for the pilots and backfill predominantly the EMP rota. Okay, so 2 more pilots. This is different data, 2 different pilots. So this is now pilots 3 and 4. I think you'll notice straight away that actually the proportion of patients now being ratted versus those that are not ratted has already increased. So we're now looking at about a 50-50 split of all patients that went through majors during the time of the pilot. The pilots went over 11 days in total, bearing in mind that the January pilot, we lost 2 days of pilot work because of the snow, because the clinicians couldn't get into work. And there's not very many hours because I could only get one consultant PA per day for the pilot. So literally we were focused in on 4 hours of each day. But we did have consultant presence. So we're starting to see the effect of actually having the team, greater number of patients ratted versus than before. And actually we used an SPR on 2 days, and I think that's really important because a lot of people might think, well, we haven't got that many consultants. We can't have a consultant here and do this. So we wanted to try using our senior registrars because actually you don't necessarily have to have a consultant doing RAT. You can have a senior doctor in ED doing RAT. So very similar data in terms of the two groups. Decision-making, referral, and the decision-making in terms of when they've been seen is actually sped up. And that is absolutely because of the influence of the consultant presence actually doing the RAT themselves. But look at the total time. It's like, damn, that's not supposed to happen. But the groups are small. So I don't know if that's a quirk, but actually what it's already suggesting is that you might well do RAT, and you might make decisions quicker, and you might refer quicker, but actually it might not make any difference to your exit time out of ED, and I'll talk about that in a minute. Put all of that data together, pilots 1, 2, 3, and 4, this is what you get. We've now got 368 patients in the database, as it were. Time to treatment consistently being achieved within 60 minutes. I think the next column for me is where the real impact is. We're referring, if we're ratting them, we're referring them in 90 minutes, compared to the traditional route where it's taking us 3 hours to refer to an inpatient team. If we're referring at 90 minutes, we have a much better chance of getting that patient onward through their journey and into the hospital than if we're referring to our medical colleagues at 183 minutes. We're not really giving them a fighting chance. And that decision-making is taking just 35 minutes, median time, versus 102 minutes for the other group. But look again at the total time in ED. And then I've been asked, you know, have you done a statistical analysis? Literally in the last 3 weeks, this is very new. King's College London have been very helpful, and they've started to look at the data. So we've done a t-test, and as you can see, yes, it's statistically significant, but obviously not for the total time in ED. Not surprisingly, it's only a minute difference. So why is that?
Sorry, can I just ask, did you look at the number of reaches in the two groups? Because
Yes.
clearly the range is interesting.
Yes.
Between 58,713
Yes.
going up to 1755 from that poor person
That-
who took up residence.
That was one
I know, but
patient.
that's an
Yeah,
extreme, which is why
it
you've
was.
got a median. But,
Yeah.
but clearly, if your hypothesis is, if your hypothesis is that the faster decision to treat, to refer gives physicians a fighting chance,
Yes.
then that would be the place where you would see it
Yeah.
in those two groups, wouldn't it?
Yeah, so I think there's a lot more that we can, because obviously we've got all the core data now, so I think there's a lot more stuff that we need to look at with the data. So we haven't yet started to look at the breach rate.
Sorry, can I just, it's
yeah.
in the same vein actually, that obviously when you're looking at your total time,
Yeah.
because I would agree with you that time to treatment and decision referral is key, and it will tie into the breach data, but presumably, I don't know whether you go on to discuss whether you broke down what the delay, from the point of the patients being referred to the time they left, did you analyse that?
We didn't analyse it in this sense, but I know what the problem is. It's exit block.
So bed availability.
Yeah, absolutely. So we do need to do more work. We've got a lot of data now, which is great, but actually we need to do a lot more work in terms of looking at the nuances of data within that and what it's actually telling us. Remember I said about this referral issue, the RAT team can refer back to ED, ED can't do that to themselves. So what about if we just look at inpatient referrals? So just the patients that were referred to inpatient teams for both groups. So that's exactly what we did. We stripped out all the other patients, just patient referrals directly from RAT to an inpatient team or directly from an ED clinician to an inpatient team. Their referral rate is about the same, 35%, 36%. One of the anxieties that our inpatient clinicians had was that we would just RAT them and refer them. So our referrals would go through the roof. Not so. And we've just done a 5th pilot, which I'll talk about in a second, where actually the referral rate's even lower. It's starting to drop because of that consultant presence. They're actually much more likely not to refer them on rather than increasingly. We didn't look at the time to treatment because it's the same. All patients have to be seen by someone, so we didn't look at that. Okay, so we strip out all the other patients. This is just purely referrals on into inpatient teams, and again, it tells its own story. If you're referring to inpatient teams at 99 minutes versus 183, that's much better. There's a whole host of other stuff that we need to look at, which this might not show. So their total time in ED doesn't look like it's been affected. But what about the fact that those patients are getting decisions earlier, getting antibiotics earlier, getting fluids earlier, getting investigations earlier, getting things ruled out earlier? Anecdotally, I can tell you, because I've spent all my time actually being on the floor, watching them and guiding them about the model and not trying to veer off on funny tangents. But for instance, we have instances where we have indeed referred to our acute physician colleagues at 99 minutes. They've been full, they've got no beds, so they come down. They see them in ED. They say, well, I can see you tomorrow in my clinic and I can discharge you home, and the patient's left the department within 4 hours. If we did it at that time, even if they tried to do that, they wouldn't succeed. So that's the sort of stuff that we now need to try and pick out, which is it's much more detailed. So here's just a summary, really, of the pilot highlights. I've already said about the time to treatment. I've already said about the time to referral. Haven't got a chart for it, but because I was physically there, there were a couple of days where we actually had AAU beds. So our acute medical unit is called AAU. And we also had beds in our own CDU. This is a rare occurrence, I hasten to add, at King's. So I specifically focused in on those couple of days, and I think we had 6 patients in each group. And the RAT group, their median time to discharge was 2 hours versus 4 hours for the non-RAT group. So why is the discharge times not really different between the two groups? Largely because we've got exit block. We cannot physically move these patients on. And we're brilliant at somehow finding a way to move a patient at 239 minutes. Yeah? We're just fantastic at it. So what I was saying to the nurses was, no, I've referred this patient really early. So let's say I referred it at 100 minutes. But they wouldn't focus on that individual because they're worried about that patient on 232 minutes who's about to breach. So actually what they do is they wait till these patients come up to 200 and something minutes, then they start to manage them out, or the system starts to manage them out. So somehow we need to completely change that. And actually on some days it did change, but it's tiny. I can't say, it's not a massive amount of data. Obviously, I'm focusing as well on the AAP role. They saw 81 of the 128 patients that were ratted, and as I've said, there were no clinical incidents thus far because they're working with the senior doctors. It's not an us and them. It's about a team approach. And I've said that. That's the big sticking point. So what's the future? We've just run a 5th pilot. This is the last pilot because we're just going to go live in the autumn. The difference with this pilot was the methodology is exactly the same, but I had 8 hours of consultant time per day. So we've now got 10 days worth of data of 8 hours a day. So the data pool is going to grow quite significantly. We're looking at go live in the autumn. Initially, in terms of consultant cover, we can only rework the rota to give us 7 hours a day. And we're looking at building specifically a rapid assessment and treatment area. So we were piloting within majors, just doing it within majors, which isn't big enough anyway. We're going to have a specific area, and I know a lot of hospitals have already done this, where the ambulances will drop off in the rapid assessment treatment area. They'll offload there. The ambulance crews can then go. We will then rapidly assess and treat them, and then they will go to majors or go to AAU or go to CDU or wherever they need to go. I think it's really important in terms of the AAP stuff. So yes, it's great that we've got this distinction between an advanced nurse practitioner and what we're trying to do at King's, but it's because we want ANPs in the future. So this enables them to have that clinical exposure, but you've got to have the educational stuff to back it up. You can't just throw them in for a couple of years and say, go and see some patients in majors, then expect them to suddenly become an advanced nurse practitioner. There's got to be that master's level educational pathway which supports that development. So this year, we've been very fortunate. We've secured 4 places on the Advanced Nurse Practitioner Masters at London South Bank, partly funded by BTBC. So now I'm panicking because I have no idea where the money is going to come from next year, and it's a 2-year program. But that's great to get it off the ground. They've got, therefore, the educational framework and the clinical exposure and support. And the aim, obviously, is to develop full ANPs. Final slide, I had to talk about cost. I actually don't have detailed costings, but I'll give you an idea. And I guess this is about just underlining that this isn't free, but actually I think it's worthwhile investment. So the new RAT area is a decision that you would have to make for your department, for your patch. For us, I said to the last group, I have no idea why building work in the NHS costs so much more than if I get my house renovated. But anyway, so a 6-trolley dedicated RAT area carved out of an existing area within ED, about £500,000, which I just find really scary. Consultant cover, as I've said, it looks like through job planning, we're going to be able to provide the consultant cover that I've alluded to with our current consultant cohort. But we really want to move to 7 days a week. And I think it needs to be longer than 7 hours a day. So there's a conversation to be had there. The AAPs, in terms of establishing it as a separate part of the rota, so you've always got an AAP on every day. For us, it's 2.5 whole-time equivalents at band 7. That includes 22% uplift that we use. So I don't think that that's a crippling cost, because what you're trying to do is establish nurses practicing as practitioners in majors with the view to having advanced nurse practitioners in the future. These guys don't rotate every 6 months, so it's about investing in your static workforce so you can develop that. The educational program that I talked about, each place is £2,500 per person per year. But actually, in the grand scheme of things, I don't think that that's an extortionate amount of money, given what we're trying to invest in and what we're trying to develop. I haven't put a cost on this, but you do need multidisciplinary buy-in and support and leadership within the department.